Good morning, everyone. Welcome on our research outcome seminar from QNRF. We organize this event not on regular basis, but at least 6 times over the year, calendar year, to showcase the outcome from our funded projects. We need to ensure developing the best strategy on women health and well-being. And this strategy should be evidence-based to provide guidance that can optimize investment in women health. Now, because in the end, it's the validity and credibility of our research studies that sets the headlines and justify priorities for these strategies. So during today's seminar, we will share with you the outcome of from 5 research projects funded by QNRF, as I said, to demonstrate the role of scientific evidence in improving public health with focus on women health. And we will start with Dr. Sawsan Riyad Ahmed. She's joining us from California, and that's why we truly appreciate her sacrifice by staying up until now, and she will be able to answer your question at the end of the session. Otherwise, the other presenters will keep their questions till the end, because we do have a Q&A session for any questions from the attendees. And at any time during the presentation, if any of our audience has a question, please just put it in the Q&A tab. If you can see it at the bottom of the screen, click on that and write your question, and we will address your question promptly at the end, inshallah. So back to Dr. Sawsan topic. As you know, studies have found that postpartum depression and postpartum anxiety symptoms are the 2 most common perinatal and mental health disorders. So our first presentation will address mood disorders among Arab pregnant women. But let me first introduce our esteemed investigator, Dr. Sawsan Riyad Ahmed, who has led the study to its current success. Well, after receiving her bachelor degree in psychology with honor from the University of California, LA, Los Angeles, she continued her journey with psychology to earn a master, then a PhD degree in clinical psychology from Wayne State University in Detroit, Michigan. Her research focuses on the relationship of sociocultural risk and protective factors with physical and mental health in people of color. Hence, she authorized several publications with this regard, with focus on Arab and Muslim communities. Dr. Sawsan is currently an associate professor of psychology at the California State University in Fullerton, California, and visiting scientist at the same time in the Department of Psychiatry at Sidra Medicine here in Qatar. Luckily, Dr. Sawsan has accepted to join us from California and at such a late time, so to present the study progress and its anticipated outcome. By the way, her study is still ongoing, but it's on its final stage. That's why we're still looking for more. And again, just a reminder, the Q&A for Dr. Sawsan will be at the end of the session, so not till the end of the whole seminar. So if you have anything, please write it down and we will address it within 15 minutes. So Dr. Sawsan, you can share your screen and you have 15 minutes. Unmute yourself, please.
Good morning, everybody. It's good evening for me, but it's good morning for you all, mostly all of you. Today, I'm going to be speaking about our project that's our QNRF-funded NPRP project, which is entitled, the presentation today is entitled A Cultural Adaptation of an Intervention to Prevent Perinatal Mood Disorders in Arab Pregnant Women. I'm going to be presenting some preliminary results and a focus on some lessons that we've learned along the way as the study is still ongoing from the Mothers and Babies Qatar project. I'm Sawsan Ahmed, as Dr. Inas just let you all know, and the co-principal investigators for the study are Drs. Darius Tandon from Northwestern University in Chicago, Drs. Felice White, Dr. Mohammed Azim from Sidra, Ibrahim, Medhat Al-Bari, Sara Bouhmaid, all from Sidra, and Dr. Ziad Mahmoud from QNRF Medicine in Qatar. So I'll be giving you a little bit of background why this is an important area of study. I'll be discussing our objectives, methods, phases of the project, and challenges and lessons learned. As you heard Dr. Anas speak about, postpartum depression and postpartum anxiety are the two most common perinatal psychological disorders. What we know is that 1 in 4 women are affected by perinatal psychological disorders. That means that they're affected by these disorders up to 1 year postpartum after they deliver. The prevalence of postpartum depression specifically, we don't know that much. We don't have a lot of data on the prevalence of these disorders in women in Qatar, but there are studies that have been published that have found that the prevalence in Qatar is 17.6%, with similar regions of that's of just postpartum depression specifically, so not all the other disorders, with similar rates seen in the region, making it higher than what we see in Western countries. For example, the prevalence rate for postpartum depression in Western countries tends to be around 13%. So there's seems to be a higher rate in our region. And the mothers and babies is a cognitive behavioral therapy-based intervention developed. It's a psychological intervention that's developed in the United States that has demonstrated efficacy in reducing symptoms of depression and anxiety, as well as preventing the onset of postpartum depression in pregnant women. Despite the fact that the prevalence rate of postpartum depression exceeds those found in Western countries in Qatar, and that there are effective and available interventions for preventing postpartum depression and anxiety, to date, there have been no intervention studies that have attempted to prevent postpartum depression and anxiety among Arab women in the Middle East and North Africa region, including Qatar. As such, the study is, as far as we know, the first of its kind to examine the feasibility, acceptability, and outcomes associated with delivering an intervention like the mothers and babies intervention to women in Qatar. So let's talk a little bit about the objectives of our project. So the Mothers and Babies Qatar project aims to culturally adapt the mothers and babies intervention for use in pregnant Arab women. And although there are numerous studies that determine the efficacy of mothers and babies as a psychological intervention in preventing perinatal depression and anxiety, Mothers and Babies was developed and validated in Western pregnant women. Therefore, before deploying Mothers and Babies and implementing it to an Arab population, it's important and essential that the Mothers and Babies curriculum is adapted both culturally and contextually to be relevant for Arab women. So the aim of our project are 3. The first is to adapt the Mothers and Babies intervention program for use with Arabic-speaking women in Qatar. And although Mothers and Babies has been translated Arabic, there are a number of cultural and contextual adaptations that are important to integrate prior to using it in Qatar. Second aim is to conduct a small pilot study with an N of 10 women that examines the acceptability, appropriateness, and the feasibility of the adapted intervention that we developed in phase 1 to be delivered with Arabic-speaking Arab women in Qatar. And the third phase is to conduct a randomized control trial, and we're shooting for an N of 210 to determine the effectiveness of the adapted Mothers and Babies intervention on symptoms of anxiety, depression, and perceived stress in Arabic-speaking Arab women in Qatar. So just a little graphic to show you a little bit the 3 phases. So in June 2019, we began the process of adapting the Mothers and Babies curriculum. We completed it in May 2020. That was phase 1 of the project. Phase 2 was the pilot phase of the project, which began in May 2021 and completed in June 2021. And then the randomized control trial, which is ongoing, where we're aiming for 104 in the control group and 105 in the control group and 105 in the intervention group. It's ongoing and we began. And so I will talk to you a little bit about each phase and what we have done. So to be included in the project, in the intervention group and the control group, to be included as a participant in the project, the inclusion criteria included being 18 years of age or older. So we were looking for women who were adults. We were looking for women who were both Arab and spoke Arabic fluently. So because we were interested in not just the Arabic language, the intervention in Arabic, but also just if it's culturally appropriate for Arab women. women had to be up to 28 weeks of gestation pregnant, because the intervention is a 12-session intervention. So we want to deliver the entire intervention before the women deliver. We want to make sure that the women are not diagnosed with a fetal anomaly that's incompatible with life, or whose anomalies will result in significant physical or developmental morbidity. So we wanted to exclude women who had a major fetal anomaly diagnosis. We excluded women who are not currently receiving treatment for mental health difficulties, who did not have a history of a serious mental health condition, and they had to screen as having some symptoms of depression and anxiety, because we wanted to target women who were at risk for depression and anxiety, not women who had no symptoms or whose symptoms were so severe that they met criteria for a clinical diagnosis and should be receiving treatment for that clinical diagnosis. Recruitment, it was conducted by Arabic-speaking research assistants who approached pregnant women while they're waiting for their prenatal health care appointments. If participants met the initial eligibility criteria during pre-screening, they then completed a baseline survey. And at the end of the survey, the participants were randomized into either the control or the intervention group. And then we assigned the participants to a facilitator who then began the intervention with them. So participants were consented, they completed the pre-screening eligibility questionnaire, they completed then a baseline if they met eligibility, randomized into control or intervention group. They then received the 12-session intervention from our facilitators. And then we've been following them up 6 months after the baseline, they began the intervention, to see if the intervention was effective or not. Okay, just a little diagram to kind of let you know about the recruitment process. So the research assistants introduced the study. If a participant accepts to be part of the study, they then sign the informed consent. We then determine eligibility. If they meet the initial eligibility, they then begin the pre-screening process, where they complete a short pre-screening depression and anxiety questionnaire to ensure that they have some symptoms, but that the symptoms were not too severe. Okay, and then they are either assigned to be in the control group or the intervention group. They then receive the 12-session intervention. They're given various vouchers along the way in the intervention to kind of encourage participation. 6 months later, they are then given a follow-up survey to test for the effectiveness of the intervention. And I wanted to now speak a bit about in more detail about the phases of the project. So as I explained earlier, the first phase is the adaptation phase. And in this phase, the Mothers and Babies Guide was adapted for use with Arab pregnant women in Qatar, and we employed the following procedures. First, we went through a review process by a team of a multidisciplinary and multi-ethnic Arab health professional team, reviewed the content of the Mothers and Babies curriculum to ensure the concepts were relevant and appropriate for the culture and in Arabic. And this included, we had individuals who spoke many of the major dialects that we find in Qatar, so Qatari dialect, Egyptian dialect, Levantine dialect, to make sure that the concepts were relevant and the languages were appropriate, and including that the concepts were relevant for the culture. And during that process, we went through many back and forth reviews by different members of the team. During that process, some of the activities in the Mothers and Babies Guides were replaced or added to be more applicable. We added culturally appropriate mindfulness activities. And the lead PI myself, with assistance of Dr. Darius Tandon, who's our co-PI from Northwestern, who's heavily involved in mothers and babies research across in the US, conducted the required trainings to our facilitators, utilizing the new adapted guides to the and as well as to the research team, so they could understand the intervention and its adaptation, as well as intervention facilitators, who were the ones who would be delivering the program to the participants. Some lessons learned during this process were that, one, literal Arabic translations for a lot of the concepts that are used in the Mothers and Babies curriculum may not be appropriate and may not make sense to our participants. We also learned that modern standard Arabic needed to be used for the guides, since our participant sample speak different Arabic dialects. It was not appropriate to translate it to Amiya or a local different dialects. It had to be modern standard Arabic so that everyone could understand. And other lessons we learned is that it was actually very challenging to think about how to capture unique psychological concepts in Arabic, since some of those concepts are not readily available or understood. especially those related to cognitive behavioral therapy. So those were some challenges, some lessons we learned during this process of phase 1. Here's an example of one of the activities in the mothers and babies curriculum and how we adapted it. So in cognitive behavioral therapy, you want to encourage your clients or your patients to incorporate pleasant activities into their day-to-day to help improve their mood. So here's an example of the original curriculum, which has things like reading a book, a magazine, daydreaming. We couldn't figure out how to actually describe daydreaming in Arabic if people would understand that. Things like getting a manicure or pedicure, we weren't sure that was very relevant, necessary to our population. So there's some of the activities we kept, some of the activities we changed. For example, we added things like visiting relatives, because that is a common activity that people do in Qatar that can encourage pleasantness and behavioral activation like we want in cognitive behavioral therapy. We added things like listening to the Quran. So we tried to, this is just a small example of some of the adaptation we did. So instead of just completely translating things, literally translating them, sometimes it involved changing the examples or the concepts. The second phase of the project was the pilot phase. So after we spent this time to adapt the curriculum, we then recruited 10 participants to complete the baseline survey and randomize them to the intervention or control group. And during that, and we tested out whether not only our recruitment process, but also the intervention was then appropriate with real participants, with pregnant Arab women. And some adjustments after that pilot phase were made, and they were implemented to be used in the randomized control trial phase. And some examples of some changes we made was how we introduced the study to potential participants. We added things like explaining how it's beneficial the study is beneficial for the community and how this is something that's not very studied in the Arab community. We changed the screening tool scores to widen the inclusion criteria because we learned from other research, including research my team has been doing, that the usual inclusion criteria screening scores are not necessarily appropriate for the sample, that you might need to widen it. And through that process, we felt that the mother and babies guides that we came up with and the sessions were considered to be acceptable and understandable to our population of interest. We added an additional section regarding gestational diabetes into the mothers and babies guide for women who are diagnosed with GDM. And that emphasized healthy living and diabetes prevention and treatment. And this is actually a sub-aim of our project as well, to see if the intervention helps women with GDM, not only for mental health, but also for their GDM. Some lessons learned during the pilot phase, where we found that there was a lack of research literacy in the population of interest, including understanding what randomization was. We had to really think about how to explain randomization and what wording to be used. And we needed to really think about how to talk about the value of research and why participants should be part of research, because it helps the community. We also learned that mental health literacy could be an issue, that participants may not understand the importance of getting help or that they need help. And we learned about stigma of mental health, that women may be worried about being linked to mental health information, and that somehow that would be disseminated to the community or to their medical health records, or their family would find out about it. So these are all kind of lessons or issues we learned during this pilot phase. And then we began our randomized control trial phase, which is phase 3 of the project and the phase that we are in right now.
Sorry,
so
you have 2 minutes, Dora.
Okay, sure.
Yeah.
We've approached 2,500 patients. 2,100 were assessed for eligibility. Most of them were not eligible for the study. They either weren't pregnant at the right time or didn't speak Arabic, et cetera, et cetera. We have 715 participants as of now. Okay, I'll go through this quickly. We have 57 participants in the control group, 54 in the intervention group. 8 of the control group have GDM, and they're in the GDM subgroup, and 16 of the intervention group are in the GDM subgroup, because again, we want to see if the intervention is also helpful for GDM. Some initial findings is that on average, and again, we don't have enough data to evaluate the effectiveness of the intervention yet, but we will have that. We are on track to meet our recruitment goals. the mean age, gestational age of the women that we recruited is they're 17 weeks pregnant when we recruit them. And we have the full range between 4 weeks to 28 weeks that's allowable for the project. On average, the women are 30 years old. On average, they exhibit 9.9, a score of 9.9 on the EPDS, that's the Edinburgh Postpartum Depression Scale. So showing that they have some moderate symptoms of depression, but not high symptoms. And on average on GAD, that's the Global Anxiety and Depression Scale, they are showing some anxiety symptoms as well with a score of 6.33. The full range of the GAD is 1 to 17. And these were all based on the baseline reports. And in terms of nationalities of our participants, majority of our participants are from Qatar or Qatari, and we have a few from the other representing the other Arab countries. And this is representative of the where we're recruiting from, because we are recruiting from Sidra. Some lessons learned during the randomized control trial phase of the project is recruitment challenges. Participants, travel long periods, so we had to, deal with traveling during the summer and holidays, and that causing a gap in recruitment, meaning less participants that we could potentially recruit. COVID-19, this project is being done during COVID-19, resulted in a lot more virtual appointments for women who are pregnant, meaning there were less patients in clinics, so less people to recruit. One very interesting challenge was incentives, financial incentives that usually work in research projects that you might do in the West, for example, are not necessarily much of a motivator in this population for participating in research. So that was something, we probably would have guessed, but it was unusual and interesting. We were trying to be flexible in how we deliver the sessions because of COVID-19 and because I think more and more people are doing things virtually. But we found that maybe because allowing for virtual sessions, which the Mothers and Babies curriculum does allow for, may result in less engagement and less commitment, because it's easier to not show up for a virtual appointment, right, than to show up to a physical appointment.
Please, you need to wrap up. Thank you.
Okay. And then we also learned that some participants were not comfortable turning on their camera, which affected engagement, and that participants valued privacy, and that some refused to participate because of privacy and being concerned about it. And we learned that some facilitators were just better at retention of their participants because they had a lot of experience with psychological interventions. And thank you. I wanted to thank the Qatar National Research Fund and Dr. Inas for organizing this seminar, and just our coordination team, which includes Mona Karayem, Farah Strad, Ragad Burjak, and Sajida Maraka, who are all actively part of the project and keep the project running. And just to open up the floor for some questions from the audience.
Thank you very much. Excellent presentation. Sorry to wrap it up quickly just because of the time limitation. I do have a couple of questions for you from one of the audience. She's asking, did the study shed any light on why depression anxiety is so prevalent in Qatar?
Yeah, so I think I don't think we can say why necessarily it's so prevalent in Qatar from this study, but from research studies that we found, it is similar to what we see in the region. And one of the, I think the big things that we're finding in other research that I'm doing that's related to this project is a lack of social support and social support from the different areas that might be important for this sample. So it's and also I think that sometimes a lot of women who are working have to go back to work right away because that's the requirement of their jobs, of not having maternity leave, a longer maternity leave that you might see in other places. So I think all of these factors together contribute to higher rates of depression and anxiety that we might see in Qatar and in the region because of those kinds of things, and probably less prevention programs and things like that.
Mm-hmm. Thank you. So another question is asking that you showed some activities from the Mothers and Babies, but in summary, what exactly does it involve?
So it's a cognitive behavioral intervention. So cognitive behavioral therapy is actually it's an evidence-based psychological intervention. There's a lot of research to support its use in various mental disorders. And it includes different components. So it includes components about teaching people about how to increase their for depression specifically, we're interested in people's So behaviors and how behaviors affect how you feel. So we understand also we're interested in cognitive behavioral therapy. We teach people how to identify their thoughts and how their thoughts can relate to their mood. We teach them how to increase social support. Because we know that this is something that research tells us is related to depression and anxiety for pregnant and postpartum women. So it includes different components of cognitive behavioral therapy in the curriculum, but those are some of the major components, including, and also mindfulness. So there's mindfulness, there's increasing social support, understanding how our thoughts influence our mood and how to change those thoughts, and also behavioral activation, so pleasant activities and things like that.
Because that would play a huge role in inducing depression and anxiety. I have a question for you, actually. It's a very interesting study, but design-wise, I think when you say 12 session of intervention, that's a big deal. How about the patient compliance? Did you find it really feasible to have a 12 session of intervention for a pregnant woman?
So that's a very, very good question. So what I didn't say in the presentation is it's 12 sessions. Each session is 15 minutes. So and we can deliver more than one session per meeting between the facilitator and the participant. So we actually aim to deliver 2 sessions at a time. So but we are finding compliance and engagement to be a challenge. But we've implemented a lot of strategies that is actually helping, but definitely it's 12 sessions, but it's not 12 full hour sessions that you might see maybe in therapy and in mental health treatment. Because if you remember me saying this is an intervention it's a secondary intervention, is to prevent postpartum anxiety, depression for women who are at risk. So it's not your typical kind of therapy. And each session is short. It's meant to be short and manageable. And the facilitators sometimes do 2 or 3 sessions at a time, and the 3 is the most, but we try to keep it to 1 or 2.
Thank you. One other question, it says, given the variety in the skills of the trainers, how does this impact on the validity of your findings?
Trainers or trainees so I think they probably,
they meant trainees. Yes, I think that's. Yes. I mean, or the skills of the trainer. Well, it's both. It works on both. The skills of the trainer and who is it the same trainer who is training everyone, or are using different trainers?
No. So the main trainer is Dr. Darius Tandon, who actually is part of the developers of the intervention, and myself, who is a licensed clinical psychologist.
So it's a consistent kind of information. We don't talk about bias. How about the skills of trainees? If we get it that way.
So the way that we were, so one of the actual aims that we presented in our research proposal is that we wanted to train people to be mental health providers and health providers in Qatar to learn about this intervention, so that other people can use it in the community who are not involved in the study. And so to receive the training, participants actually had to have some healthcare training. So we had nurses, we had psychiatry residents, we had clinical psychologists early in their training. So we don't just have people in the population. And by the way, research actually shows that the level of experience and does not necessarily predict mental health outcomes from intervention. So it's actually, it tells us that a lot of people can deliver mental health interventions. Doesn't mean you don't have to have training. Of course you do, but we can teach people to deliver some of the not so complicated interventions, and you don't need to have a PhD in clinical psychology like myself to deliver an intervention like this, and this way we can help more people.
It doesn't involve any sophisticated basic science or something. It's something I think with a professional trainer, definitely you can get quality trainees. Thank you very much, Dr. Sawsan. I wish we can have you more, but the idea, we have many other items, and my apology to the other people who had other questions, but that's fine. I will share it by email with Dr. Sawsan, and she can address you by email, address every question by email to get the reply. Thank you very much. Appreciate it that you stayed up late at night. She's joined us from California, as you know, and we look forward to see you, inshallah, at the end when you finish the project, and good luck with the study. Thank you.
Thank you.
Now back to our second presenter. Let's see. It's about breast cancer. So let me go back. Yes. So breast cancer, as you know, is the most commonly diagnosed cancer and the leading cause of cancer death in women worldwide. But unfortunately, women are being diagnosed with more advanced stages of breast cancer, with a higher proportion of women in their 30s and 40s. Hence, the need for an objective scoring of breast cancer tissue, which is the topic of our second presentation. But let me first introduce our lovely presenters who's joined us from Belgium. Thank you so much. Eric is currently a full professor at the University Library. I hope I'm reading it right. De Bruxelles, that's in French. Excuse my French. Now, his genuine dedication to excellence has generated 5 patents, 252 publications, and in a peer-reviewed journals he received more than 10,000 citation actually with H factor 54. That's huge. And but let me go a little bit about some other background. He has a Professor Eric has a PhD in chemistry from that University University Libre de Bruxelles. And he was able to successfully develop an infrared spectroscopy for the study of membrane proteins and lipids. Consequently, he started studying cancer cells growth in collaboration with different hospitals in Belgium, France, and Switzerland. Breast cancer was at the center of his research. Over time, his work came up with millions of FTIR, which stands for Fourier Transform Infrared spectra. So he was able through over time to accumulate millions of FTIR spectra. At the same time, he was able to design and build the necessary tools and analysis procedures to exploit such wealth of information. And honestly, the list, his 40-page CV, it made it so hard for me to summarize in a couple of minutes, but I'm so proud to have you, Professor Eric, with us. So the list goes on and on about his achievements, but in short, I would say Professor Eric is in fact considered as a European leader in the field of FTIR spectroscopy of biological molecules, cells, and tissues. So let's enjoy his presentation first, and we will reply to your questions, dear audience. Once you have any questions, just put it in the Q&A. And luckily, Professor Eric will be able to stay till the end of the seminar so he can address your questions. Now, if you can just please share your screen and unmute yourself.
Okay, can you hear me?
It is. Yes, yes, very well. The floor is yours. You have 15 minutes.
Okay. Right. So, thank you for the introduction. I tried to.
You're welcome. That's a minimum.
I have to discuss very much about the importance of breast cancer in the region. And as you can see here, breast cancer is the most prevalent. Here, you can see my pointer, I suppose. And it's also the most deadly cancer in Qatar. So its rate is increasing. And so it's really important that we deal with this. So there have been recent improvement in diagnostic, prognostic, and treatment. And one of the most important tools nowadays is genomics and transcriptomics. So very briefly, it addresses the genes and gene expression, and it helps classify the cancer. But I'm going to be really short in this presentation. But overall, we can say that the contribution of genomics applied to the treatment of breast cancer remains moderate, even though there have been really interesting progresses. So there was a need to go beyond genomics and transcriptomics. And there are two main reasons: that the gene from the tumor, they do not describe the molecular heterogeneity of the tumor. So routinely, it's almost impossible to get a picture of the genomic of every cell in a tumor. So if you know about this one, you don't know, well, you have to know about all of them. And they can be quite different because they are mutating, especially when the cancer gets older. I mean, there are new mutations, and so you have different types of cancer that coexist in the same tumor. And that's really difficult to grasp. using these techniques. And second, there is something which is even more important, is that a cancer is growing, but it's surrounded by an environment that is extremely important for the future of this cancer. So this environment, it can be the immune cells, it can be the other types of cells that are surrounding the tumor, and they are talking to the tumor, and the tumor is talking to them through chemical molecules. And this is this crosstalk that is really important, and that decide finally whether the cancer is going to be more invasive or less invasive and so on. So there is a definite need for a microscopy technique able to recognize the cells and the subtypes of cells and possibly their state, whatever it can mean. And this is why we started this QNRF project. So I just want to show you a section in a tissue. So the tissue you see here, it's about, the size is about 0.5 millimeter. So it's a microscopy. And you can see here this nice, this is a normal tissue in breast. You can see this very nice double layer of epithelial cells here that is forming, that is surrounding a duct. This is where the milk is flowing through, actually. And you can see outside, you can see these, the collagen, and sometimes you can see a fibroblast in the collagen. So this is a normal tissue, but you can see it's already very well organized. Now, if you go to a cancer tissue, it's much less, it's of course disorganized to some extent, and it's hard to read, but here you can see you have tumor cells here. This is a part of a tumor, but surrounding the tumor, you see all these black dots. These are lymphocytes. So this is the immune cells, the immune system that is coming to kill the cancer, but probably doesn't. It's stopped by some mechanism. And it's very important to understand this mechanism, which is the state of these immune cells. Why are they not killing the cancer? What are the mechanisms? What are the molecules that stop them, and so on? And you can even see inside the circles, you can see some lymphocytes infiltrating the tumor. So, so this is to show that you really need a microscopy technique that can provide a unique signature for all the cell types. And the most promising approach today, we think, is infrared spectroscopy or infrared imaging. Just in a word, infrared, if you look in the visible, the bright light, you know when you have a rainbow, I don't know if you have many rainbows in Qatar, but you know what it is. You see light has different colors. You can split the bright light into blue, green, yellow, orange, red, and so on. And what we're doing in infrared spectroscopy, we are working here in the infrared range. And in the infrared range, we record spectra like this, where you can see, so this is again the wavelength, if you want. And we record spectra, and the shape of the spectra is extremely sensitive to the chemical contents of the cell. So it's a type of microscopy that look in the infrared and provides information on the structure of the proteins, on the lipids, on the DNA, and so on. So altogether, it forms a unique signature of the cancer cell. And what it does, so here again, you have an image of a duct with the epithelial cells, normal epithelial cells surrounding it. If I look in the infrared at one wavelength, they appear in red. If I change the wavelength, they appear in blue. And if I for instance, ratio the two images, they really are highlighted here very well. So you can recognize these epithelial cells very easily. And they are very sophisticated mathematical tricks that are much more sophisticated than what I presented here, that allow to identify the different cell types. And at the end of the day, you can identify cancer cells which are normal or medium grade or high grade and so on. So just by looking at the spectrum. But in this presentation, I want to focus on the environment. The first type of environment is the lymphocytes, the immune system. And you can see on the left, you can see these immune cells, the lymphocytes here in these small dots are the nucleus from the lymphocyte. And this is a mathematical treated image of an infrared image. And you can see that you can recognize the lymphocytes. They appear in blue, and they account for about 65% of the area. And that's already very important, because nowadays, at least in Brussels, I know that some pathologists, they are counting by hand the lymphocytes in order to have a good prognostic. So they base some part of the prognostic on the number of lymphocytes present in the tumor, infiltrating the tumor. So it's already a very fast way to identify the lymphocytes and to relieve the burden from the pathologist. Now, it's even more than that, because you can make the difference here between the B lymphocyte, the T lymphocyte, and the CD4, the T lymphocyte, CD4 positive or CD8 positive. So using infrared spectroscopy, again, you can identify not only that they are lymphocytes, but also the type of lymphocytes and where they are located. So that's one aspect. The second aspect I wanted to highlight is the collagen and the stroma. So what is outside the cancer. And you can see that every dot here is an infrared spectrum. And you can see that normal stroma is very significantly different from tumor-associated stroma. And if you go to a tissue like this, so you have the tumor here, you have the collagen, so that's the stroma here. And if you draw a line, so first, if you look at the interpretation of the infrared image, you can see that you very well recognize the tumor, you very well recognize the stroma. But if you go deeper in the analysis and you draw a line here, just from the tumor going outside, you can see that you have a factor that we have the spectrum of, that decays exponentially with the distance. So we can describe things that do not appear at all by any other means. And these things are really important, because this is what make the tumor invasive or less or more invasive and so on. So I think the time is flying. So just to almost finish, no, I still have 5 minutes actually. We tried to also build with our colleague in Qatar, we tried to build an improvement of the methodology. And one way to improve the infrared imaging is to add some kind of external information. And in Qatar, they had this very nice machine that allows to measure in an imaging way the elemental analysis. So we can, for every pixel of the image, we could know how many carbon, phosphorus, sulfur, chromium, manganese, iron, nickel, copper, zinc, and so on was present. And it has been shown for already years that 93, 97, that the amount of iron, copper, zinc, or phosphorus, sulfur, and so on was different in the tumor. So it's related to the tumor process. So what we did, we developed this new approach, and we tried to image. So this is an example. I mean, this is just six tissue sections here. And what you can observe is the amount of phosphorus, chromium, manganese, and so on. And you see actually that it's not, for instance, here in this corner of this tissue, you have a lot of copper that but you don't have anything special about phosphorus. So there are differences that are related to something very specific of the tumor in that part of the tumor. So we try to combine. Here you have the infrared images, for instance. Here you have this is the carbon image, but that could be zinc or whatever. And we spend a lot of time to overlay the image in order to have them, to analyze them together, and that to have something really very solid, very strong. And that was not easy, sorry, because I mean, the pixel size and everything was different in the two methods. But at the end of the day, we could achieve a clustering that that is based largely on infrared spectroscopy, but there were subclusters that were highlighted by the presence of the elemental analysis. So that's something really new and very nice that even further improved the capacity of infrared imaging by adding this, so by adding the elemental analysis. So in summary, we could identify using infrared spectroscopy the main cell types and even some kind of grading of the carcinoma. We could count automatically the infiltrating lymphocytes. We could identify the lymphocyte types, and so that's an insight into the immune environment. That's very important. And we could also characterize the tumor microenvironment. I was talking about these fibroblasts that are talking with the cancer, that are exchanging information, and the cancer is telling the fibroblast something, and the fibroblast is also telling the cancer something. And they can grow like this. So we could image that, in fact, in the 2 dimensions. And finally, we got a combination of the infrared and elemental analysis to provide a further improvement in cancer tissue segmentation. So I'd like to acknowledge the QNRF from Qatar and Dr. Khalid Al-Saad, who initiated the project and conducted so successfully over the years. And I also would like to thank the contribution of Dr. Rafif Al-Sadi from the laboratory medicine at the Al-Hali Hospital, who provided all the tissues and all the information that the pathologist can provide. And also Mohammed Ali and Fazle Rakib, who recorded millions and millions of spectra. That's really impressive. I mean, it was so many data that it was hard to transfer them between Brussels and Doha, even with the internet as it's working today. So all that resulted in a very nice paper. Also, I mean, one of the last paper, because we had several, that the creation of that innovative platform merging elemental analysis and FTIR imaging for breast tissue analysis. And I thank you for your attention.
Thank you. I was trying to stop just like a minute earlier, but you wrapped it up just on time. Maybe just an extra. Thank you, Professor Eric Gormaftef from Belgium. This was an excellent presentation. Actually, when I read the research, it was hard to me to grasp some basics, but you simplified it in a very nice way that I can give you some question, but I'll keep it till the end, inshallah. So to my understanding, all the samples were taken from Qatar. Am I right?
Yes. Yes.
Okay. Good. And you still have that wealth of data available for the spectra that you used? It was analyzed?
Yes, yes.
Okay, good. So maybe that's good for future study, inshallah. Thank you very much. And I hope you to keep you stay with us till the end, inshallah, to address some of the audience questions. Thank you. Now we need to move to our next topic. I would say women have to go through radiological exam more frequently than men. For example, during mammogram tests, pregnancy follow-up, all these things. So given the absence of information on radiation doses in mammography in the Gulf country, our third presentation will address safety concerns in women's imaging. It's so critical to know when you get exposed to any of this ionizing radiation, what would be the consequences going through these tests frequently. So the study will be presented by Dr. Mohammed Kharita, who was one of the main key investigators in this research. Dr. Mohammed has obtained his Master of Science degree in Applied Radiation Physics. Then he earned a PhD degree in Radiation Dosimetry. Both degrees were from the University of Birmingham in UK. Subsequently, he was able to successfully occupy many high-rank positions at multiple industrial and healthcare facilities between Syria, Austria, and Qatar, which reflected Dr. Mohammed's broad knowledge and expertise in the field of radiation safety. On top of that, he has a vast experience with the International Atomic Energy Agency, IAEA, as an expert to more than 40 missions. Dr. Mohammed Kharita is currently working at Hamad Medical Corporation as an Assistant Executive Director of Occupational Health and Safety Department. He's also the Director of Medical Physics Section, overseeing all medical physics aspects in diagnostic radiology and radiation safety issues among all of the 15 HMC branch hospitals. Now, despite all the above responsibilities that I mentioned and many positions that he's holding, Dr. Mohammed was eager to conduct many research studies and published around 40 publications. His index is 14. And today's presentation is nothing but another example of his determination to make a difference in the field of radiation safety. So please, Dr. Mohammed, the floor is yours for 15 minutes only. Share your screen, please.
Thank you very much, Dr. Inas. Yeah,
you're welcome.
I'm very humbled. I'm in front of this very nice presentation. I hope thank you. I hope my screen is visible to you.
Yes. Can you move it to slideshow?
Yes. Okay.
Yes, perfect.
Thank you very much, Dr. Inas. Thanks for all audience and thanks for our presenters as well. Assalamu alaikum wa rahmatullah, and good morning, good evening to everybody all around the world. And my presentation will focus, as Dr. Inas already mentioned, about women imaging. And we will focus on two issues, mammography and in this project, and CT. And that's because CT is a high dose protocol usually, and the mammography is only for women usually. And so I'll go on. The project was between 2016 and 2019, so that's have to be shared. So it's already conducted, and we already have several publications. I'll go through the presentation, and this is the scheme of my presentation, and I'll just introduce my. I'm speaking on behalf of all all investigators in the project, namely Dr. Huda Nuaimi, which is the lead investigator, and myself, Dr. Antar Ali, and from Harvard, our collaborating institute, Harvard Medical School, Professor Madan Rihani, Dr. Kara, and Dr. Anand. And I could say in between us, we have all the specialties. So we have medical physicist, a radiation safety specialist, a radiologist, and specialist mammography physician. So these are the group who are conducting. I'm speaking on their behalf. Just to confirm what already mentioned by my previous professor Eric, about my previous speaker who spoke about breast cancer, which is most common among women in the whole world, not just in Qatar, but also in Qatar. Due to the low participation in breast screening as well in Qatar, this is special for Qatar, women in Qatar are often diagnosed with breast cancer at an advanced stage of the disease, unluckily, due to not participating in the breast screening. The good thing as well, in breast cancer mortality rate are decreasing in most high-income countries, including Qatar, despite the increasing or stable incident rate. And that's due to better care and better treatment of breast cancer. So this have to be mentioned. The second point, there is a lack of published data from Qatar about the extent of usage in CT in pregnancy. So, and the adherence to the best practice. So we find no publication before the year 2015 which has any information about Qatar and radiation and pregnancy. So if you share these words, you will not find anything before 2016. And that by itself indicates how important this project is. The second point, although we will speak about CT, so we have, although unjustified multi-phase CT exams must be avoided, it's more important to reduce the frequency among women in childbearing potential. So this is really important to focus, and that was one of the focus of the project. This group of patients, especially in the conservative countries in the Middle East, was a special challenge since the acquisition of written informed consent about the likelihood of pregnancy is constrained by the prevailing social etiquettes and norm. So this is another challenge related to our area. So after that, just the objective of the project is to study the quality and safety in breast imaging. That's the first part, and in CT imaging of women of productive capacity in Qatar. So we want to make sure that the doses from CT to women who might be, might become pregnant in the future should be minimized or optimized at least, or avoid if possible. Second point, to develop guidelines to improve appropriate and safe use of ionizing radiation in women imaging, I should say. To establish best practice and guideline in HMC hospitals for women imaging. And the last objective is to have the result of the study as a basis for formulating national plan to track radiation doses of patients and implement all the outcome of this output of this project. I'll just summarize the outcome of the project in a few points, and luckily it's already, most of them are published. So the first point is already published about the evaluation of radiation doses of patients undergoing mammography in Qatar. So all 4 papers coming as outcome of the project were published in 2020, just after the finish of the, after the finalization of the result of the project. So the first comprehensive, this is the first comprehensive project, not just in Qatar, I think in the Gulf area as well, on patient radiation doses in mammography. It concluded that radiation doses are higher in comparison with other countries. This could be attributed to the larger compressed breast thicknesses. So if we go to the quality, one of the major contributing factor is the large breast, compressed breast in the area. On average, is higher than other areas in the world. That's why the doses are slightly higher, or on average are higher. So this is the first outcome of the project. And the second one is about identification. The project, we participated in multi-country through this project with multi-country data collection about multi-phase CT protocol in 18 countries, including Qatar and the US, and a few other countries, and it discovers some important finding, and it says, it identified that the use of multi-phase CT for routine chest and abdomen pelvis CT examinations in 18 participating countries, including Qatar, is unnecessary. A lot of unnecessary exposure due to this. And further, I could use from the conclusion here, if you can see me here. So multi-phase CT examination were unnecessary in 100% of routine chest exams. Of course, I'm talking about CT exams, and in 63% of the routine abdomen pelvis. Now, this is relevant to all countries in the, on average, in all the country participated in this, not just Qatar. So Qatar is one of them. It might be less or more, but this is the average of all countries. So the conclusion that multi-scan protocols for routine chest and abdomen pelvis CT examination are unnecessary, and their use increases the radiation dose. So this is really important. Now we projected the same study on women. So the next publication was of multiple abdomen pelvis CT of women of childbearing potential. So women in pregnancy age, like let's say below 45 years and above 18, or above, so multi-phase abdomen pelvis CT for women of childbearing age potential are frequent. So this is one of the discovery. It's frequent and seldom justified. So we are talking about multi-phase, like phase 1, phase 2, contrast with post, pro, etc. So the conclusion that multi-phase pelvis CT exams frequent but seldom justified for women in childbearing potential, they lead to a substantial increase in unintended radiation doses in comparison to the single phase CT. The third outcome, I could say, bold outcome as well, demonstrating that images do have a desired information. So when we assessed all images related to not just mammography and CT, all images have a good quality, and they have all the desired information for making diagnosis, but the radiation doses can be further optimized. So we found a lot of room for maneuver to reduce this doses in CT and mammography for using better quality control procedure, more strict protocols to follow the quality of the images and increase the quality. So this is one of the findings that, okay, this is published as well, that breast cancer detection in Qatar, evaluation of mammography image quality using standard assessment tools. We came to the conclusion that most of the images were acceptable for interpretation with minimal area identified for improvement. Very few, about 93% are excellent, 5.2% are good, and only 1.21 are averaged, and the rest are, poor or fair are almost zero. Okay. So this is summarizing the outcome of the project, and I could say that the project beneficiary, it's woman and patient and staff. So the potential beneficiary include patient, women who undergo breast and CT examination, and in addition to the healthcare professionals like doctor, radiographer, nurses, medical physicists, and radiation safety professional, who are better equipped with test knowledge in the field, with optimized techniques for imaging. So we have good teams now in Hamad Medical Corporation from all different health professional orientation to conduct better imaging. As a result, it's anticipated that the beneficiary could be patient and professional in Qatar and other countries as well in the region, who might get motivated by the results achieved. The benefit to Qatar as a whole, this kind of research has a direct benefit to patient in Qatar. The gain can be visible in due course in terms of lower radiation doses for that patient are receiving, which in itself is important contribution. Moreover, most of the result of the project are first time in the Gulf region. So that's another motivation, another good another advantage for Qatar. Potential for improved health of women and increasing intellectual merits of medical imaging professional in Qatar. This is as well as a direct benefit. The summary is the project was focused mainly on imaging of women, mammography and CT, especially in women in childbearing age, and the specific situation required attention of women imaging in mammography and computed tomography for women in childbearing age. I could as well say that as a result of the project, we have few recommendations, and most of the recommendation has already implemented actually, and we can see the result because we finished the project in 2019, published the data in 2020, and since 2020 we managed to implement most of the recommendation. So the studies of this kind have direct implication on, as we said, on enhancing patient safety, should be encouraged. If they for areas other than the covered in this project, which is women imaging, we should encourage to have more studies on other areas as well. A plan to assess impact of the project on long-term reduction of patient doses be created. We already have some improvement in the quality procedure in I have a list of things which I can mention as implemented already. Next, development plan to oversee the patient radiation safety in women imaging be created and implemented. And we should have a national plan to track radiation doses of patients should be introduced and implemented. This is already introduced in Hamad Medical Corporation and CIDRA. We have since 2018 actually an HMC radiation dose monitoring system which monitors all patient doses including women. CIDRA as well at the same time have a different but similar tracking system. So we can say we have 80% of the patients are covered under this system in Qatar. Wide propagation of the result achieved through this project in countries in the Gulf region should be harnessed and harness the benefit to other countries in the region. And before I close, I would like to thank you all, and I tell you to enjoy the moment and the event of the World Cup in Qatar. But let me just highlight this few points. One mention that we have a monitoring system already. We have as well a new project with the IAEA as one direct result of this project to have a remote quality control procedure for mammography and for general X-ray. So because we have annual quality control, but within the year, we don't know what happened in the system. Unless there's a breakdown or there's some maintenance, we don't have like routine quality control by the medical physicist. So now we have a project to have a remote QC. So we have designed some phantoms, and these phantoms will be, this project will go from 2021 till 2025. So it's 5 years project. And we already designed the phantoms and implemented some part of the project. As well, we reviewed all quality control procedures to improve our quality imaging from the medical physics point of view. And this is done through a new procedure, updated procedure, and a new data sheet to control our result and improve and reduce the likelihood of a human error. I could finally, I would like to acknowledge really the big and important contribution from our staff in Hamad Medical Corporation, especially from clinical imaging. I would like to acknowledge the contribution from Dr. Ahmed Omar, who is the chief radiologist, who really helped us a lot in this project and contributed a lot. Dr. Shaza as well. Dr. Shaza from clinical imaging department, and
you can wrap up, please. Yeah, you're running out of time. Yeah.
Yeah, I finished actually. Dr. Amal Ubaidili as part of the project. They were two partner in the project, and some other who were as well partner from the clinical imaging. And I would like to thank you all and enjoy the occasion, as I said, and really thank you very much. I hope I didn't take more than I should.
Thank you. Just a couple of minutes. That's fine. But we really, truly, I mean, from I'm speaking on my behalf. I mean, myself, I really enjoyed it, and I think everybody did, because this is a good news. I mean, at least we're limiting this impact of ionizing radiation on our body. There are some efforts. There's quality control check. These are all good news, and we're happy to hear that. Unfortunately, we have timeline to go with, so we're already behind the time, and we will thank you very much, and we will be receiving the questions for Dr. Mohammed. We'll address all the questions at the end, as we agreed. Please write your question in the Q&A tab. Do that, and so we will get you all the answers at the end, inshallah. Let's move to our next topic. The fourth presentation in our event today is going to be about sexually transmitted infection, which has been identified as a major cause of women infertility, miscarriage, and ectopic pregnancy in the MENA region. So we truly need more studies on STDs in MENA region. Now, during our fourth presentation, we will learn how can we define such public health problem and what should we do next. Which is so critical, because time is running, and we have to take an action, since its impacts really infertility, miscarriage, and ectopic pregnancies can be caused by STDs. So our presenter, Dr. Hiyam Qimatli, is one of the key research team members in the project. She obtained her Master MSc in Epidemiology and Population Health from the American University of Beirut in Lebanon. Afterwards, she earned a PhD in Epidemiology and Population Health from London School of Hygiene and Tropical Medicine in the UK. Dr. Hiyam's research interests are in conducting epidemiological studies with primary focus on sexually transmitted infections, using state-of-the-art methodologies and tools such as mathematical modeling, advanced statistical analysis, as well as meta-analysis and meta-regressions. As of today, she was able to publish around 100 research studies in highly reputable journals such as Nature and The Lancet, which reflects the high credibility of her research outcome. Most importantly, her research work has been instrumental in informing public health policy with a broad international media presence. Dr. Hiam is currently working as an assistant professor of infectious diseases epidemiology at Weill Cornell Medicine in Qatar. And Dr. Hiam, are you with? Yes, here you are. Please share your screen, and we would love to hear.
Can you see my slides?
Yes, I can see it.
Okay.
Thank you very much.
Thank
You
you.
have 15 minutes, and we'll keep the questions till the end. That's for the audience. Thank you. You can start now.
Thank you very much for the introduction. So today I will be presenting key findings on chlamydia trachomatis infection and its impact on women's reproductive health in the Middle East and North Africa region. So what is chlamydia? Chlamydia is a sexually transmitted infection. It is caused by the bacterium Chlamydia trachomatis. It's a curable infection. However, it is usually asymptomatic, and therefore it is very easy for it to go undetected. And if left untreated, chlamydia can cause poor reproductive health outcomes such as pelvic inflammatory disease, ectopic pregnancy, and infertility. And given the consequences of this infection and other STIs on global health, the World Health Organization formulated the Global Health Sector Strategy on STIs with a primary goal of ending STIs as a public health concern by 2030. Now, to achieve this global health sector strategy, the first strategic direction is to generate evidence to better inform response and help countries progress towards the elimination goal. In our region, the epidemiology of chlamydia is poorly understood. However, our region is estimated to have the highest rates of primary infertility worldwide, as well as high levels of secondary infertility. So we conducted this work to gauge to what extent chlamydia contributes to the high rates of infertility in our region. We defined our region to include 23 countries that extend from Morocco in the west up to Afghanistan and Pakistan in the east. And this region comprises about 10% of the world population. So the primary objective of this work was to comprehensively characterize everything related to the epidemiology of chlamydia in MENA. And to this end, we looked for all sources of data on chlamydia infection. We surveyed the scientific databases, and in partnership with the World Health Organization and UNAIDS, we also worked with countries to get routine data that are not published. So after this exhaustive search, we ended up with 495 chlamydia prevalence measures that we used to synthesize and to generate estimates about the prevalence of chlamydia in our region. So using meta-analyses, we estimated that the prevalence of active infection is about 3% in the general population, which is comparable to global levels. But it was for us surprising because normally we see lower STI infection levels in our region compared to other regions of the world. As expected, we found high active chlamydia infection prevalence levels in high-risk populations. It was, for example, 13% in female sex workers and about 8% in men who have sex with men. But surprisingly, we also found very high prevalence levels of active chlamydia infection in women with miscarriage and infertility clinic attendees. So over 1 in 10 women with miscarriage and over 1 in 10 infertility clinic attendees had an active CT infection at the time of diagnosis. This is, of course, very high. We also estimated the prevalence of lifetime exposure, and we found that in the general population of MENA, 7% had ever had a chlamydia infection at some point in their lifetime. Of course, this prevalence was much higher in high-risk populations, for example, female sex workers. But again, surprisingly, we found very high levels of lifetime exposure among women with poor reproductive outcomes. Over 1/3 of women with ectopic pregnancy have had an active CT and have had a CT infection at some point in their lifetime. And over 1 in every 5 infertility clinic attendees also have had chlamydia infection at some point in their lifetime. Now, we wanted to quantify the risk of exposure in the different population groups, and we used meta-regressions where we controlled for different confounding factors. And these confirmed the results that I showed you earlier. So relative to the general population, women with miscarriage and those with infertility clinic attendees had 3-fold higher risk of chlamydia infection. Similarly, women with ectopic pregnancy had 5-fold higher risk of chlamydia infection. So the key findings from this research work is that chlamydia prevalence in the general population in our region is comparable to global levels, but it is higher than expected. And this relatively high prevalence may reflect the fact that in MENA, we don't have chlamydia screening programs. And therefore, if a woman gets infected, she tends to live with the infection for a long time without it being detected or treated. And this, of course, the bacterium can travel through the genital tract, cause damage to the fallopian tubes, and result in miscarriage, infertility, or ectopic pregnancy. The risk of chlamydia infection was at least 3-fold higher in women with poor reproductive outcomes. And this suggests that chlamydia could have been the main cause behind miscarriage, ectopic pregnancy, and infertility. So in this region, chlamydia infection burden is largely hidden, it is neglected, and it is underappreciated. However, its consequences are very visible, and it has a heavy social and economic impact given the value of childbearing in this region. So this highlights the need for targeted and culturally sensitive programs, such as chlamydia screening program for women in reproductive age, which are standard in developed countries. However, not a single MENA country has a chlamydia screening program for women. Now, this research was a story of success. First, it was published in Lancet Global Health, which is the leading journal in global health in the world with an impact factor of 39. And given the importance of the study, the journal solicited commentary on it by leading infertility experts in the field. Also, the study generated a lot of interest for WHO, which provided us with an unsolicited grant to extend this work to gonorrhea infection, but this time at the global level. And this study was published in the leading journal on STIs, and in fact, it featured on its cover page. Now, this work that I showed you was part of a larger QNRF funded project on HIV, AIDS, and STIs over a duration of more than 7 years. And based on the studies, some of the studies that I accomplished through this project, I was able to build a very robust career and to complete a PhD at the London School of Hygiene and Tropical Medicine, which is the 3rd highest ranked university in the world in epidemiology only last year. And based on these accomplishments, I was recently appointed as an assistant professor of research in population health sciences at Weill Cornell Medicine, Qatar. And based on also the accomplishments in this QNRF-funded project, WHO designated us as a WHO collaborating center, and this center was inaugurated by Her Highness Sheikha Mouza and Her Excellency Dr. Hanan Lukwari, Minister of Public Health, 2 years ago at the height of the COVID-19 pandemic. Now, also all the training that I got through this project came very handy when COVID-19 hit us. So we were very prepared for leading the epidemiology component of the COVID-19 national response. And based on the research conducted as part of the national response, where I was the lead analyst, we published 57 articles. In fact, tonight at midnight, we will be celebrating our 12th publication at the New England Journal of Medicine, which is the most prestigious journal in medical research in the world. And these accomplishments are exceptionally unique within the context of the modern history of medical scholarship in our region. It appears that before these 12 studies, there was only one paper from our region ever published in the New England Journal of Medicine. This work on COVID-19, which was all made in Qatar, informed guidelines at the CDC and WHO, and was presented numerous times at high-level meetings, such as by Dr. Anthony Fauci in his White House press briefing and in a US Senate testimony. And it generated a lot of interest and was covered widely in international press and media, such as at New York Times, Washington Post, CNN, among others. And
You
this
have 2
really
minutes
all
to wrap,
shows,
please.
yes,
Yeah,
the potential we have to excel in Qatar with the right investment on science. So I would like finally to say thank you, QNRF, for providing the opportunity to achieve all these amazing scientific accomplishments, and for me personally, for the opportunity to achieve my scientific career dreams. Thank you very much.
Thank you, Dr. Hayam. You are welcome. I always say you are a rising star, and we're happy to have you going through all these, challenges during COVID, and yet your study with the leadership of Dr. Laytha Buraddad from Well Cornell, you excelled in overcoming all the obstacles and met the deadline and submitted a lot of interesting reports, actually. And that's besides the long list of publications. So we're so proud of your work. Thank you so much.
Thank you very much.
Good luck with your future project, and all the questions, as I said earlier, please leave it till the end, inshallah, after we finish our last presentation. Dr. Salha, are you with us? Can you unmute yourself, please? Dr. Salha from Hamad Medical Corporation, she faced difficulty in accessing Zoom from her laptop, so we're trying to, I'm going to show her presentation from my computer, and she will join us by phone. Hello, Dr. Salha, are you there? Thank you, Dr. Salha, for joining us. Let me just introduce your work. So as you know, dear audience, breast cancer is the most common cancer among women in Qatar, which is a global issue. Actually, it's not only Qatar. But Arabic women are often diagnosed at advanced stages, as our previous presenter already highlighted this issue. So that's why, due to various reasons that will be discussed during our fifth presentation. So we will be going through or digging through why are women in Qatar kind of reaching the healthcare facilities at late stage, not earlier than that, despite having all the screening program, breast cancer screening program available to them. So Dr. Salha Al-Badr will help us to go through the outcome from her work in collaboration with the University of Calgary in Qatar. A bit about Dr. Salha. In 1992, Dr. Salha has earned her medical degree MBCHB from King Saud University in Riyadh, Saudi Arabia. Subsequently, she became board certified from the American Board of Internal Medicine in Clinical Hematology and Medical Oncology from Toronto, Canada. Most recently, in 2018, she received a master's degree in molecular oncology from the European School of Oncology. Dr. Salha research activities focus on breast cancer, gynecological malignancy, and cancer genetics. Most importantly, she received an honor award for highest academic achievement as Qatari female physician in internal medicine. During her tenure at HMC, she has established multiple services unique to cancer program. One of those is ACGME-1, Accredited Medical Oncology Fellowship. Additionally, Dr. Salha is the founder of Hereditary Cancer Genetics Program in 2013, Hospital-Based Standard Risk Breast Cancer Screening in 2008, and the Breast Tumor Board in 2005. Currently, she's working as a senior consultant in the Hematology Oncology Department, also a director of fellowship in Hematology and Oncology program, and she's also the clinical lead for the breast multidisciplinary team. Without further ado, let's listen to the impressive outcome from Dr. Salha's study. Dr. Salha, you can, we're in the first slide right now. You can view it, right, from your
Yes,
side?
yes, it is
Okay.
very clear.
So the floor is yours, my dear. You have 15 minutes.
Thank you, Dr. Layla, for your invitations. I'm happy to be with you to present the collaborative study that done between HMC, BHCC, and supported sponsored by QNRF and the University of Calgary. The lead BI of that collaborative work was Dr. Tam Dondi. So for next slide.
Should I move?
Yes, please.
Yeah, okay.
So my agenda for this presentation, I'll talk about epidemiology and background of breast cancer, and I will describe the material method, the study populations, results and conclusions, and final recommendation. As you know, women cancer are especially devastating and might life-threatening conditions. For most of patient treatment is complex, involve multiple specialties that may include surgical oncology, medical oncology, radiation oncology, and palliative care medicine. Multiple drugs can be used to treat breast cancer, such as chemotherapy, immunotherapy, hormone therapy, as well as supportive care medicine. There is substantial variation between countries in both incidence, risk factor, and death rate for breast cancer patients. This is cancer registry showing that breast cancer is the most common cancer in Qatar, accounting for 40.8% of cancer affected women. Next. So how we can achieve our goal in improving the clinical outcomes. Of course, we need to improve our patient care, involve in many research as we can, and also enhance educations for both healthcare workers and also for public awarenesses. And as you know, the month of October is Breast Cancer Awareness Month, and most of the world they celebrate this day to increase awareness of breast cancer. As you know, like early diagnosis and early detections can save patient lives. Next. So how we can control breast cancer? It is as cancer strategy launched in 2011, the in general cancer 4 pillar of for cancer control, including the breast. The first pillar is prevention and early detections through the national breast cancer screening and standard risk for patients with standard risk, and also high risk screening for cancer susceptibility genes that associated with breast cancer. And also breast cancer awareness. So the women, they need to know the early signs and symptoms of breast cancer so they can come early on and diagnose the cancer in early stage. And also the diagnosis and treatment that include imaging, pathology, molecular testing, using the latest advance in technology and using precision medicine treating in diagnosis, predicting prognosis, and also to guide the treatment. The molecular and precision medicines is very important elements in diagnosis and tailoring the treatment for patients. New therapies such as immunotherapies and targets. Nowadays, we cannot treat any cancer without having a target treatment or including immunotherapy, which have a lot of advances in treatment of patient and prolonging the life of patient. Also advanced in radiation technology and medical oncology and surgical techniques. The most important also is not just to treat the patient, but also to improve the quality of life with better toxicity management for advanced treatment, support a patient and integrated care from early diagnosis until the end of life. And also we have to concentrate on mental well-being and identifies, take care of the survivor. The survivorship program is very important elements in cancer management. With the aim of survivorship is to identify the effects, establish surveillance strategy, and also focus on the lifestyle modifications like healthy diets, physical activities, and avoid the thing that increase the risk of cancer. Next. So how we can improve the quality of breast cancer is by encourage integrated care and quality to access what we have already achieved. We should not just provide a woman with a treatment, but also help her to go through it. Ensuring women can continue their personal and society responsibility through psychosocial support along every steps of the patient journey to prevent or reduce unnecessary suffering. And so at the time of conducting this study, we already established the pilot study for standard risk breast cancer. So we have done this hospital-based screening in Qatar, started in January 2018 to April 2015. And, to just test whether the patient will accept breast cancer screening for a journal publication. And we did a lot of advertisement, and it is kind of initially in the early stages was self-referral through breast cancer campaigns and awarenesses. And as you can see here, from population and from 2008 until 2015, the numbers is continuously increasing, and people they comes to check the breast themselves. And this is the time where we conducted our studies with QNRF. Next. During our pilot study, we found that there is a lot of patients, young age, they come forward to do screening or surveillance because at young age group, and they are, not fitting the criteria for standard risk. So that's why we developed our cancer genetic program for hereditary cancer syndrome. And we design a special criteria and screening using guidelines, international guidelines. And our result was published in Cancer Genetic Program follow-ups. Surprisingly, we found that we thought that the BRCA-associated genes or Lynch genes is rare in our society, but with this study and with the recruitment of patients and coming forward and detecting patient who's meeting the criteria for hereditary cancer syndrome through our MDT, found that there is a BRCA incidence in our society is remarkably high. Next.
Yes, can you see the next slide? Factors that influence, yeah.
Yes, okay. A rationale of that study, there was a study published earlier by Dr. Binar and Etel in 2009, showed among Qatari women, 24% do breast self-examination and 23% have clinical breast examination and 23% have had mammography. So they found that there is a low rate of screening, suggests that Arab women in Qatar are at high risk lack of early detection and treatment of breast cancer in early stage. Thanks. So the research question was, what are the participation rate for Arabic women in breast self-examinations, clinical breast examinations, and mammography screening? And to what extent are Arabic women culture, knowledge, and value the knowledge of breast cancer and its screening, and also assessing through the questionnaire the socioeconomic status, how the participation for screening practice and link between psychosocial status and the social support network, and also how it is linked or associated with the breast cancer behavior. Next. And so the patient methods, data were obtained through the interviewing participant that use structured survey questionnaires to ensure that information gathered reflected experience of women living in various areas in Qatar, participated and recruited and were interviewed in urban hospital setting and community health clinics in the capital Qatar and some semi-urban areas in south and north of Qatar. The sample size was calculated using 95% confidence level interval formula for sample size. So the study questionnaires focus three elements. Participation were assessed with mammogram awareness. Participants were assessed with having performed breast self-examination on a monthly basis, and also whether the patient has a clinical breast examination within the past 2 years.
Yeah, 3 minutes, Victoria, to wrap up, please.
Okay, so this is, I think it's very crowded, the slides, but I will come to the conclusion of the result.
Okay.
Yes. So the present study found that the women levels of knowledge of the most recent national guidelines for breast cancer screening practices in Qatar is low. Approximately 3/4, 73.6% of women interviewed were unaware of mammography. 73.1% of women 40 years of age or older had not had mammography within the past 2 years. Of the participants who had received the breast screening practices information, approximately 2/3 had received a breast cancer screening information from the media, 62.7%, or their doctor, 62.5%, while approximately half of received breast screening information from family member or friend, 54%, and healthcare provider other than doctors is 47%. Approximately, non-Qatari resident participate were significantly more likely than Qatari citizen. And the study indicates that the strongest predictor for having a breast cancer awarenesses were having a doctor who talked to the patient about the breast cancer and in screening. Higher education level, secondary third school they are more likely to participate in the cancer screening practices. Next. So for conclusion and recommendation, Qatar is a rapidly growing country. The Qatari government to provide subsidized or free healthcare services, modern state-of-art medical facility for residents. However, the awareness and participation of breast cancer activities is low. And they conclude also to promote the breast health and awareness of national recommendation for breast examination screening. And the healthcare provider must be encouraged and talk to the patient about the breast cancer and benefit of breast cancer screening and population-based screening program with a guideline specific to Qatari social, culture, and healthcare context, and also to enhance national cancer registry, multi-sector and multidisciplinary intervention program devoted to raise awareness of breast cancer and breast cancer prevention, and also the research program that evaluate the effectiveness of this intervention strategy in addressing breast cancer in Qatar. Shortly after this publication of our effort, it was launched the cancer strategy, and one of the elements of cancer strategy was to develop national breast cancer screening. And it was I was with them in that committees when we started our national screening for first time in Qatar. And I think thank you for QNRF and and our collaborator in assessing the person awareness, and it was the start of having a national screening. I was very happy to have those, and it is required, and it is part of international guidelines to prevent and detect breast cancer. Thank you all. Without collaboration, we cannot achieve our goal. And there is a lot of work need to be done and to improve breast cancer awareness, and also to increase the breast cancer screening practices in Qatar. We still have in our MDTs and multidisciplinary meeting, a lot of patients develop breast cancer and came in for treatment with locally advanced and metastatic setting. I hope with time these numbers is decreased. Thank you.
Thank you, Dr. Salha. Very interesting topic, and I really like the fact that, alhamdulillah, our study, the funded by QNRF, contributed somehow to the national, breast cancer screening program. So it raised importance, and hopefully the input from your study outcome what made a difference in improving the healthcare services offered for women. With God forbid, I mean, I hope everybody get the opportunity to have early detection rather than stay at late stage. I do have a couple of questions. So all the presenters, please, are you there with me? I would love to have you. Yes. Glad to see you all. Dr. Salha, also please stay with us. So here is the Dr. Afnan, I think. Anyway, she's asking about what exactly are the risks of high exposure to radiation? Dr. Muhammad.
Yeah, thank you very much, Dr. Inas. Yes, I read the question. I think she used as well high exposure. So high exposure to radiation have a very bad effect on our health. And it can be, if it's very high, it has deterministic effect. So it might have a tissue reaction like burns on the skin, like hair loss, etc. But that's only in very high doses, like in what we experience as a patient in radiotherapy, or high doses of total body irradiation in radiotherapy might give us some deterministic effect. The rest, what we experience as patient in diagnostic radiology, for example, we only have very low doses. These low doses might increase our likelihood of developing cancer in the long term. So this is what we call it random effect. So the higher the dose, the higher the probability of having cancer in the future. But this is what they call it, the non-threshold linear relationship between dose and effect. So this is only random effect. So if I correctly answer her question, high exposure, that means we might reach like deterministic effect like burns, hair loss. But in our doses, what we expect patient to receive in diagnostic radiology procedure, even interventional radiology, we are unlikely to receive any except for like a interventional cardiology, where patients are undergo long procedures, like in 50 minutes or 60 minutes, then he might develop burns on the skin. Otherwise, it's unlikely to develop any deterministic effect in diagnostic radiology. The only risk is only stochastic risk, which is mainly the fear of developing cancer in the future, and that the probability of having cancer is proportional linearly with the dose.
Thank you. Got it. So the issue here, that's my question actually to you. You mentioned about tracking this radiation per patient. I like this idea. So like if you have a record for if I do investigation, I mean, for example, I do a mammogram with certain center, and they do have a record for me, like how much what the amount of radiation that was exposed to? Because I know with the ionizing radiation, it causes irreversible damage to the DNA. So that's what we're trying to avoid. So if there is any track to whatever exposure I experienced, in order to avoid reaching the optimum limit.
Okay.
You mentioned that tracking radiation patient. Could you please elaborate on that?
Yeah.
If this is something,
There's two issues here. It's very excellent in Qatar, actually. The first one is having archiving system. So we have one archiving system in the whole country where even if you have like an X-ray or CT in Al Khor, the next day you are in Al Wakra and your doctor can access the same image you had it last week or last year or the year. So the archiving system is accessible by all hospitals and health institution. Secondly, we developed that we have as well a tracking system for radiation dose. So as you said, each patient, when he goes under CT examination, then this CT examination will at the end of the procedure, it will tell him that this dose is so and so, and is recorded and monitored. So on the long run, as you mentioned correctly, when you have accumulated doses, when you have multi CT examination in 1 year, then you might reach very high dose where we think this is you are
it's too risky to proceed.
It's you are reaching the risk zone of more than 100 millisieverts, especially if we're talking about pregnant women. Then we have to really monitor all patients, but especially pregnant lady or ladies in childbearing age period.
Can we just move to when we reach that limit, the optimum limit, we can move to the sonography, right? I mean, that's another
of
way,
course.
but
Always,
I believe the image wouldn't be as good as the quality as the
yeah.
X-ray.
I might say justification is the key. Any image which a patient has to go, especially high dose procedure like CT, has to be justified, has to be a clinical justification. Otherwise, it's better to use ultrasound or MRI if as well, which is available as well, which is non-ionized, non-dose procedure, zero-dose procedure. So that's really advisable always to have alternative method if you can to avoid any radiation dose to patient.
Thank you very much. That's very helpful, and I hope at certain time we may have this. I mean, it's already implemented, right? Like as you said, if I go to any.
We have this system of tracking those in all Hamad Medical Corporation institution linked. All the radiology equipment are linked to the same software, and we have the doses for all the patients. I can tell you from 2018 it was installed.
Perfect.
November 2017 actually. Till now, I can give me any patient. I can give you all the doses.
Perfect.
During
Thank you so much.
2 years.
Good to know. I have a question for Professor Eric Gurmaftov, please. Doctor, you mentioned I like the term that you mentioned there is a grading the carcinoma. So how efficient is using this FTIR in grading the carcinoma? Because as you mentioned earlier in your presentation, it's the advanced level that we reach. So if I get low grade cancer, then this is something will help me with early management. So how efficient the spectroscopy that you developed in grading carcinoma?
Yeah, there is a correlation between the grading presented by the pathologist and the infrared spectra. That's all we can say. So once we train the system, after having a certain number of different patients, then we can start predicting for the next patient what the grade is. But it has not been so far developed to the point that we can replace the pathologist.
Okay, so we're still in the back school. I mean, the old school, the histopathology and the clinical picture and all these things. But in the future, at certain time, inshallah, we will be reaching this and make it implemented.
It's really an issue. I mean, because we have always we need to know if we want to train a system using infrared spectroscopy, for instance. We need to have a gold standard, and the gold standard is often. I mean, the pathologists, even among them, they disagree, and there is a certain level of disagreement in difficult cases. I mean, not in extreme grades or so. And so it's not that easy because of the heterogeneity of the breast cancer and all the practical examinations and assessments by the pathologist.
Yes,
So,
it's got to be.
There is a good correlation, but
Of
I
course.
wouldn't say we're going to replace the pathologist by the system we have so far. So we would need more training and more
Of course.
testing. Yes.
Yes, thank you very much. Dr. Hiam, I do have a question for you. So I remember you mentioned this is based on a systematic review, the outcome that you got. And I wonder, have you got enough studies in Qatar about chlamydia?
There has been a study actually conducted by Dr. Asma Al-Thani. The number of studies is limited, but there has been some work conducted by Dr. Asma Al-Thani. And she also found very high prevalence level in the general population in Qatar. I think if I remember correctly, the prevalence was about 5%, and there was no difference between Qatari women and resident women. So this also suggests that there could be many women living with the infection for a long period of time. In Qatar.
So overall, I mean, when you think about it, STDs in general, you know, the stigma comes with this. So it's not easy when people try to avoid being diagnosed with such a thing. But my question is, I mean, we're in 2022. I mean, people are more, I would say, more aware about having research and doing studies like that. Is it possible to do like a regular screening for such a thing for example, let's say a convenience sample, whoever comes to the clinic and do a gynecological test for something? Maybe that's a kind of study rather than just relying on a few limited published work in Qatar. I know there are very limited number of studies about STDs here. I wonder if there is any plan for a screening program, as you mentioned, which is the best choice is to rely on hard evidence and make it on a big cohort that's kind of representative to the problem here in Qatar.
Yes,
is there any plan to?
This is an excellent question. This is actually what we are trying to push for. And as you mentioned, we are in 2022. So, and actually people may be more open to undergo such screening than we may think. So for example, one of my colleagues recently conducted a survey among refugee women in Lebanon. And the survey was based on measuring several STIs. And they were surprised by how open the women were to actually screen for STIs.
Good.
So maybe we are over-exaggerating the stereotype. But I think one key factor is that people don't even see the consequences. So for example, if a screening that will cost me a very small amount of money can help me avoid later on paying an arm and a leg for an IVF.
Exactly, yes.
Then people will be more willing to actually screen and have early detection. So I think we have to make that link for people because people don't see it.
So we need awareness campaign, if I say, awareness about the
so if this can prevent
Yes.
So if this can help them prevent infertility or secondary infertility and all the costs and the social burden that comes with it, then I think people will be more willing to undertake the screen.
Inshallah, in the future. Dr. Salha, I have a question for you. You're with us, right?
Yes.
Yeah.
Actually, I have one comment regarding the STD screening.
Please.
You know, yes, HPV, herpes virus infections can associated with cervical cancer.
Yes.
And it is worldwide to do screening for cervical cancer. And if you early detect HPV, they can treat it and then prevent cancer as part of early detection and prevention. And I agree with Dr. Hibad, there is a lot of social stigma, but I think when we can conduct survey to see the acceptance of people doing screening, which is now standard of care for all most of the countries to do the HPV screening. Pap smear is one of it, and there is also prevention. I mean, there is vaccines. So if you detect any pre-malignance, you can give patient vaccination.
But the vaccine should be at like, what, 14 years old or something like that. I've heard it's at an early age and before having the virus. You know, just
yes,
like,
exactly.
So we need first to do pap smear, ensure that she's not infected, and then we can, it can be helpful to have the vaccine. Otherwise,
Yes.
if she already had it at some time, with low rate, I mean, this still she's not, the vaccine wouldn't help her. So it would be nice to have a regular pap smear, you know, like reminder for women based on their age and based on the database from HMC, just like the way we receive reminder about breast cancer screening,
Yes,
the mammogram.
exactly.
It would be good to have a reminder for the pap smear. But my question to you, Dr. Salha, the breast cancer screen program, you have, what's the range? Is it between for women between 50 and 65? If you can remind me.
If you can see, like in our epidemiology, before setting up the age,
Yes.
we reviewed our cancer registry. And we found that, you know, our patients, they develop cancer at younger age group compared
Yes.
to Western countries.
Yeah.
So the committees, actually, when we try to implement the cancer screen in Qatar, we select to have younger than 50. So
Exactly.
it started at the age of 45
Yes.
to 69.
Yes.
Because based on our registry, that the average, average age at diagnosis of cancer is 47 years old.
Mm-hmm.
So we set it up at age of 45.
So there is a plan to expand this into more than, and to reach at least, you know, I would say 5 or 6 years plus minus from both sides. So I would say from 45 to 69, you said that would be a good.
Yes.
So you expand the range to avoid skipping any cases at late stage. The early detection
I think it is now currently this is the age, but I think we are reviewing all cancer registry. So probably also will lower it a little bit down based on the updated cancer registry data.
Thank you. Thank you very much. So I truly enjoyed it, and I don't see any other. Let me see if there's any more questions. Oh yeah. Okay. So it says, hi, is there now any screening for HPV and cervical cancer at different age, especially in middle-aged women, and vaccines in early age in Qatar or other Arabic countries? Dr. Salha, if you can help me with that, or Dr. Hiam.
This is what I'm advocating for. Up till now, there is no national screening. There is opportunistic screening done in the women clinics or in women hospital after delivery. They do pap smear and in the primary health center, but it is not national screening.
So thank you. Dr. Hiam, regarding the chlamydia test not being present in the region, wouldn't be it hard to introduce, especially among the unmarried youth, given the stigma with STDs? Is this disease only transmitted through intercourse?
I mean, it is a sexually transmitted infection, but I think, as I mentioned before, women will be open to undergo screening if they become aware of the consequences of the infection and if they really want to take care of their health. And at the same time, screening and treatment can be done in a confidential manner. It's like very similar to like the HIV clinic where you have a lot of patient confidentiality. And I don't think that this should be actually a barrier for not doing a screening program. On the contrary, we can do a screening program and just set the right grounds for it to be gender specific, to be culturally sensitive, to try to actually reach the elimination goal.
If we offer the test for free, like as a regular screening funded by the government or something, that would be helpful because nobody would pay extra money to do this on a regular basis whenever they. My suggestion was that, as I've told you, I use a convenience sample. Whoever go for any other problem, gynecological problem, following on obstetrical disorder or something, any problem for women, whenever they reach the clinic, you can just simply do the sample since you will go into a gynecologic gynecological test. The issue is the cost. Is this something affordable so we can go further and do this test on regular basis and collect the actual number? It would be very helpful, I think, to see the size of this public health issue, since currently it's in the dark.
Yeah, I think, I mean, at the beginning, we can start by screening married women when they present to the clinic, like the pap smear. It should be like offered once a year to women. And I don't think, I mean, there could be many schemes to have these preventive screening as part of a national program, like similar to the breast cancer screening and other kind of like blood tests that we do, the blood sugar test or whatever that we do once a year, which is very acceptable, and people are willing in many ways to pay for it, but they're not willing to go and do a screening for STI.
To your understanding, I know you're not a pathologist, but do you think, from your experience with dealing with many publications in that field, do you think it can be transmitted through not through intercourse? There are many other ways of transmission for chlamydia.
For chlamydia, the other way of transmission is actually from mother to child. And it can cause severe consequences for the newborn. It can lead to neonatal conjunctivitis, and it can lead even sometimes to many abnormalities and death.
If not treated on time.
If not treated.
Thank you, Dr. Hiam. Professor Eric, I have a question for you. Thank you for your excellent work. Can the combination of both imaging, the FTIR imaging, LIICP, MS imaging, you presented, improve the clinical sensitivity of breast cancer diagnosis?
Yeah, I mean, this is a proof of concept that we have. We have worked on a few tissues, not maybe 10 or so, but not enough to really have a clinical diagnostics. So it has the potential to do so, but it has now to be demonstrated to be extended to a larger number of patients. That's all I can say to the right now.
Okay. Okay.
I'm sorry, but we had to start somewhere, and we did the proof of concept, but we don't have yet the sufficient number of patients to really say, yes, we can introduce that in the clinic and start testing.
So there's ongoing work to continue until it gets ready to be implemented at clinical setting. Thank you very much, Professor Eric. Again, the question about STD. So when the women have to go, okay, but it's okay to check for STD when the women have come to something else. What if they don't want that? well,
you cannot force people. You cannot force
exactly
on people. So it's always optional. But the thing is that people are willing to screen for blood pressure, for blood sugar. But when it comes to women's health, I don't know why women are so reluctant to take care of their own health and to do like preventive screening for things that are very important and that can affect their childbearing activity. It can affect their children. It can affect so many things. So it can lead to cancer.
Yes.
So
true.
Yeah, it's of course optional.
It's important.
But I think we have, with the gynecologists, I think we have to work on this. You know, a woman that presents once a year to do her checkups.
Yeah, at least. Dr. Mohammed, I do have a question for you, please. There is a very interesting fact that when you mentioned that the bigger the breast, the more radiation they need because of the thickness of the tissue. And that's something, I know in general, genetically, I think Middle Eastern woman has a bigger breast than the, in general, I see from, it's just a common knowledge. So that means they are more exposed to that. I would definitely go with I don't know if there's any protocol the radiologist will use. How can you balance between safety issue and the quality of the image? Like, okay, she has a big breast, but there is a high chance she's a high risk patient. So I may expose her to a radiation that might be itself harmful to her, or that little tumor may be sensitized by this radiation and make it even more serious. So how can you balance with that regard? Do you have any guidelines, any protocol?
Yeah, we have actually. Thank you very much for the question. It's it's important and is statistically evident from our sample.
Yes.
So as you confirmed as well that this is a real known fact, well-known fact. So the reality is the dose in general in mammography is not too high. And the importance of the detection is really the quality. So we need really crispy images, very high quality images, and very important to have as well, even screen, especially to detect, to read mammography images. You can't read it on normal X-ray, let's say, workstation where you can diagnose X-ray. General X-ray images. You need special because mammography is very sensitive, and you need to have very high quality. Back to the dose. The dose is not too high, even if the breast. I'm just comparing because we said our study showed that it's slightly higher than other countries which we compared with, and the fact that this higher is like 20 to 30% is not significant to create any extra damage. Like if you are worried about sensitization of radiation, biologists might not agree with this term, that the radiation might, but at least you will increase the dose, the likelihood of having another cancer in the breast if there is no cancer. But that's like you are 1 per billion. You are adding just
so there is very low chance.
So just really usually with mammography we say it's the fear of having another cancer is negligible completely. So we just focus on the quality, but nevertheless we try to compare and not to boast any doses without any benefit. Okay.
Is there any plan for referral to MRI, for example, if she reached the maximum dose?
No. There is
not cost efficient.
No, not to do with the cost. It's the best detection method is mammography, is X-ray. This is the better. Of course, it's always done with combination with ultrasound as well. If there is some specific issues, we might go to some other modality, but this is the best modality now is X-ray in combination with ultrasound.
Good. Thank you.
Thank you
so we have only 5 minutes to wrap up. I would love to hear from every one of you. If you like to add anything, you think we missed any important information that you'd like to share with the audience. Would like to start with you, Dr. Mohammed.
No, thank you. I would like to thank QNRF for supporting us all and giving us the platform as well to express and to highlight some of the important outcome of the project, and to thank everyone who participated in the project. And thank you very much.
Any plan to submit again for another grant?
Yeah, we would love to. Yes, there's a plan in there.
Thank you. Professor Eric, what's your plan?
I'd like also to thank the QNRF. I mean, that made it possible to have this work, because even in Belgium or Germany or so, we didn't have that machine for doing the elemental analysis on it was not available, at least. So it was really wonderful, and to work with so dedicated people in Qatar, it was really very nice. And so, well, I hope that in the future we can keep working together, and that's really important indeed, because it's always slower than we would like. I mean, we show something, we show it's possible, then it would require almost another complete project to finalize the idea and show it's going to work in the clinic, and then later on they would need clinical tests and so on. So it's really slow, but I enjoyed very much this project, and I'd like to thank you also yourself for dealing with this meeting so nicely.
Forgive my French. I couldn't spell the university name, but I did my best.
Arabic. I don't speak it at all.
Thank you very much. It was lovely to listen to your presentation, and I really enjoyed listening to the outcome of that work. Looking forward, inshallah, to see it implemented at some time. Finally, we can see Dr. Salha. Okay, good. Please, your input. What do you think? What's the future of your work? And if there's anything else you would like to add to our audience?
I think the most important is to early detection and early diagnosis of breast cancer, and also preventions. You know, as you know, the screening is two elements in the screening. The standard risk screening that's, you know, it's aimed to early diagnose breast cancer. But the other one is detection and the prevention. Like, you know, even before develop the cancer, we can prevent it. And it comes like, you know, the hereditary cancer, because, you know, we have unique breast cancer presentations and we have different genetic makeup in our populations. So we need to focus both in standard risk screening for early detections, but also the screening for genetic predisposing gene that develop breast cancer. And this is what we do in NCCR. We have high-risk genetic clinics, and if there is any family history of breast cancer, or there is a personal history with certain features, we do usually screening and also apply risk reduction strategy.
Wonderful.
So we have to combine all effort to screen the patient, and also you know, there is a lot of responsibility among the society to support campaigns and awarenesses and encourage women to participate in breast screening. And the study actually, it highlights the importance that the people, they knows about breast screening, but they are not participating. And you know, our health providers, they have to address this. Whenever a patient comes for routine visits, they have to talk to them about breast screening.
Raising awareness, Doctora. I think raising awareness should be a key component for the success of early detection. And unfortunately, they are still waiting for last minute until she sees some symptoms, and then she would go until she identify a nodule or something, which is sometimes too late. Sorry, Dr. Mohammed, would you like to say something?
Just to add, thank you very much about screening. Yes, because there's a question from Afnan Al-Malik talking about the same subject, screening, and she said, I like the word, suggestion of a screening is an offense. So for ladies, and this is really a reality. This is one of the big challenges we faced when we talked about this screening program and the importance. And I can say that in the West, and Dr. Eric can confirm that, they have trucks where they move mobile mammography system where women can go in on and have. And we have this actually. We have this machine sitting in Qatar and never been used. Never been used. Doctora Sarha maybe knows better than me. This never been used because it's the cultural stigma associated. Yes, and this is the offensive nature of assuming or participating or thinking about having screening. So I think from your platform here is really important. Especially
it would be wonderful to screen young age. If I take it to Qatar University and start with a student there, it would be lovely.
Yeah, I mean, this is
especially those with the history, like her mom or her whoever family history with a strong family history. Those have I believe 20% more susceptible to have breast cancer. Those with positive family history. So it would be nice.
But the high risk, they need to be seen by genetic counselor, because you cannot do it for all population. We need to verify the family history. We need to see, like, you know, how strong, and we can do also the genetic counselor. Actually, when they interview the patient, they will not only do like family pedigree and family history, but also they counsel the patient about the implication of doing the test. We are not just doing the test if it is positive and then we'll leave them alone. You know, we need to do high-risk surveillance. It include like mammography or MRI alternating. It's totally different surveillance than a standard risk. And there is also risk-reducing surgeries. You know, if there is a BRCA positive, then they will suggest to them, like, you know, bilateral mastectomy, bilateral hysterectomy. So it is not done by any usual practitioner. It should be done in the setting of the cancer genetic clinic. and interviewed by the expert people to discuss all of this implication. And the genetic counselor is very important. They have very important role to discuss this issue.
Hopefully that would be maybe a future project to start screening genetically, if that's possible, with those who are at high risk, you know, with family history.
You know, we have, I don't know whether you heard about it or read about it, because we have a very good project, excellent project with Qatar Biobank. And we found that the participant and the general population, they discover incidental findings of BRCA gene. So we confirm it in our hospital and the lab accredited, CAB accredited laboratory in Hamad. And we involve those who discover, they coming just for general checkup in the biobank, and they discover that's a BRCA gene. So they refer to us. And we did genetic counseling and also they involved in our high-risk screening.
Very interesting.
This is very important, is to use the research outcome in clinical application and clinical, you know, we can help the patient. And this is pioneer.
At least they should show more commitment into that detection early screening program. Those who are at high risk, start at early age, be more regular, that kind of thing. Dr. Hiyam, your last, you know, advice or whatever you would like to share with the audience before we leave.
Well, I would like to second you all on and to say that women should really take their health more seriously, and something that can be treated with a dose regimen of antibiotic can prevent a lot of suffering. And I would like to thank you and thank QNRF for the generous funding that made these studies possible. Thank you for inviting me to present today for these research findings, which are, I think, are important to disseminate.
Thank you. Delighted to do. I'm really thrilled and happy to see you, your work. Any strategy needs evidence, and what you're doing is definitely at some point will contribute to improve the current policy and come up with something even better for the health sector in Qatar. Thank you very much. I truly appreciate that.
If I can just comment on this point. We actually in Qatar, Qatar has made a large investment in the medical infrastructure and the platforms for information system. And in the COVID-19 pandemic, we were able actually to leverage that. And Qatar is currently competing scientifically and providing new evidence in relation to promote a better understanding of the pandemic. So actually we have everything we need here to actually success and excel. And this is all thanks to QNRF initiatives. So
thank you. Glad to hear that. I'm so happy to hear that. Thank you very much, everyone. And we wish you the best of luck with your research work, your career, and wish you all the best. Feel free to apply again and again for more successful studies, inshallah, in the future. Thank you to my audience who stayed with us till the end. And thank you for smart questions, and wish you all the best of luck.